My name's Hamish Kerr. I'm moderating today's session, and I'm very excited to be able to introduce Neeru Jayanthi, who's going to be talking to us about sports specialization. Neeru, if you want to move to the next slide. And you can see here the title, Sports Specialization, What's the Problem? So we're going to have an insight into that from uh, Neeru's perspective. Just as a few kind of logistical issues. We've got next week, we've got another talk, Sports Pharmacology by Dr. DeLuca. So just get that on your calendars for next Wednesday night. As a reminder, use the chat function, and if you're able to, certainly join us with your faces. We would appreciate it. And let's see if there's anything else I meant to. This is meant to serve as an adjunct to what your program's doing. It's not meant to be an all inclusive curriculum for sports medicine programs, but we're trying to give you guys access to board relevant topics, and we have a committee that decides what topics get included each year. We've been circling back to some of the topics that we covered 3 years ago because we've been doing this for 3 years. There is some board exam questions at the end, which we'll get to. And if you want to keep going with the slides, Neeru, like we've mentioned everything, submit your questions to the chat and I will ask those. And there will be an evaluation at the end. So I'm just going to start by introducing Dr. Jayanthi, who is the director of the Emory Sports Medicine Research and Education Program. He's also the co-director of the Emory Youth Sports Medicine Program. He is a world-renowned expert in tennis medicine and is a recipient of the AMSSM Foundation Research Awards on more than one occasion. And that's something that we wanted to mention today to this audience, because some of you will be considering your own research endeavors. And this is an area that Dr. Jayanthi has really been able to explore more thoroughly because of funding through the AMSSM Foundation. And that's something that is available annually. So we would really encourage you to look into that if you're interested in having research as part of your career. Dr. Jayanthi did med school in Loyola Stritch. He did his family medicine residency at Rush, and then was sports medicine fellow in Indiana University, graduating in 2003. So he's been a 20-year AMSSM member and is currently serving as the associate professor in the Department of Orthopedics at Emory. I have really enjoyed reading his research over the last few years. It's really kind of an area that all of us are interested in, and especially those of us that look after kids. We really consider this a major issue. Whether it's a problem or not, I'm going to let him delve into. So it's my pleasure to welcome Dr. Jayanthi. Neeru, the floor is yours.
Well, thank you so much. And, I just noticed I was looking on Hamish and Dr. Margot Patukian, one of our past presidents, has just joined us. And now the pressure's on. I wasn't that, nervous about making sure. And Margot's great. I know she's on to make sure my jokes work. So Margot, be patient. Yeah, she wants to make sure. Yeah, she wants to make sure they're good. I know that she's there checking my. So. But I will reiterate one thing that you said. This whole trajectory for me happened in so much in large part because of AMSSM. In 1998, I was beginning my family medicine residency, and to look at the things that I've been able to do now and to see where I've come. If you had asked me 25 years ago that would have happened, I would have told you got to be crazy. And, so for those that are kind of newer to the organization, all you do is just join, be active, and do what you say you're going to do. And that's all I did for every year. And then, you make friends and and you work hard and you end up getting involved. And I was fortunate enough to get, actually, I think I got about 5 AMSSM grants. And I mean, I love it. They've catapulted so many publications and other things. So I do strongly recommend that and get involved if you haven't already. And so, I get asked to speak on this quite a bit, and people kind of give me different titles. And I think we should be objective. And I like saying sports specialization. What's the problem? Okay. Follow me on Twitter. I only rarely put something up with my kids, but it's almost all sports medicine stuff and updates on publications and conferences that we're running. And I am as a disclosure, unpaid consultant to numerous youth sport organizations throughout the country. And another disclosure is I'm also a dad of 2 young boys who play sports. So I guess that makes me a qualified expert in this area if the research doesn't do it. So, what is the problem? This draws a lot of reactions. Okay, so early sports specialization, what's the problem? Well, this might be Margot, for example. She might look at it and go, well, let me look at the data before we make a decision. She's very measured and focused on these things. Maybe someone like John D. Fiore would be like, no, it's a bad problem. You can't do it. It's not good to specialize. And then there's me. I'm like, hey, let's just have fun with it and keep doing research. So I think it all depends on how you want to phrase this. Is this actually a problem or not? And I think we have to be careful. I've been a part of about 10 different position statements and review papers, and I think we've gotten ahead of some of the data on some of our conclusions. So I want to make sure that we're balanced when we're saying things. So we also want you to do well on boards. I actually recertified, or I just took the test. I hope I recertified only a few weeks ago, and I actually saw a few questions on some of the work we do. And so this is a question we'll kind of give you answers at the end, but youth athletes have been found to have an increased risk of overuse injury due to all of the following, except training more weekly hours than age, sports training ratio less than 2-to-1, high degree of sports specialization, or female sex. So kind of put that in your back pocket for question number 1. We have a second question that I kind of wrote up this afternoon here. And when counseling a family regarding sport participation during developmental periods, based on the available data, all the following are true, except, so do youth athletes in pubertal growth have the lowest risk of overuse injury? Should you delay resistance training until they're skeletally mature? There's not an increased risk of injury based on age of specialization, and youth athletes in pubertal growth may consider focusing on strength and coordination to reduce your risk of overuse injury. So kind of think about those, and then we'll circle back to them at the end of the talk. I will reiterate one thing, especially if there's younger sports medicine providers on there, the biggest complaint is we don't see enough athletes. Well, one way to do that is get more athletes. Our job should be in promotion. So there's a participation model of physical activity in sport. So we have to be advocates for that. So we get more people active and get more people playing sport. And in that, maybe some of them might end up getting hurt. A secondary model is a performance model, and we should still look at that. We're experts in athlete care, and so that's the benefits of workload, not always the detriment, but the benefit of workload for resilience. So I think those are 2 concepts we'll do before we talk about just sports specialization. When I think of sports specialization, it's 2 things, or many things, but 2 of the things are how it affects an individual, but also how it affects a system. As an example, when it affects a system, that's how is it affecting a whole like a youth sport organization, like a baseball leagues in the area. How it affects an individual is, do you get hurt? Do you quit your sport? And I think they're 2 separate things. The individual risk is also your quality of life. Like, you might get hurt, but is that always a bad thing? We have some data we're going to talk to you about that. And then you can put out as many statements as you want, but about 1/3 of athletes, which is 20 million of the 60 million youth athletes in the country, are going to specialize. So you have to have a plan for that. So we've recently published some guidelines on how do you manage the athlete who's already decided to specialize. And so, I'm living it too. I actually had to ask my 8-year-old, who's a very good tennis player and plays baseball and basketball. The coaches at his tennis academy, say he needs to be there a couple more times a week, and he's the only one who's only going once a week because he's got other sports at 8. And I asked him, what would you like to do? He said, I think if I play more tennis, it's probably too much. So I took the 8-year-old advice, and we're going to stay as the only kid in his entire academy to play 1 time a week. So he has time for basketball and then baseball, and then he'll play with me was his goal. And that is a hard thing to do. And so sometimes we're out there and getting, as a parent, you're kind of getting pushed in different directions, and then eventually you just get pushed off the edge, and it's too late. So when we talk about youth sports specialization, it's going to encompass a number of these factors. And, like I said, I've been so fortunate that, and I've seen Margot at probably a number of these places. Red Dot is, many of the places that I've been able to speak around the country on this topic. It used to be only American places, but I learned that this pattern and progress was happening all across the world. And whether it's IOC or in different other countries. And I asked them, I said, no, we're doing the same thing you guys are now in America. So culturally, what we have, it's like McDonald's, it's bleeding over in other countries as well. And so, I would also encourage you, if you're doing work and someone from media contacts you, I end up speaking to a lot of people who agree with me, and I need to get this type of messaging out to people who may not always agree with me. And that's actually what media does. So we've had no less than 200 media requests about this particular topic itself, and major to minor to local, but that's where you reach your constituents. And otherwise, if you don't get out there, I think you're just talking to people who agree with you, and you're just waiting for them to get heard. So my first question, and this is again, we're going to do an evidence-based approach to try to stay away from just opinions. Does early specialization lead to elite performance? So if you do that, hold on one second, my kids are, hey, you guys, I'm giving a talk. Sorry, try and have 8, 10-year-olds go to bed in time. So does early specialization lead to elite performance? Are you trying to develop a million youth athletes, or try to find that 1 in a million athlete? And the reality is, this is a participation model versus the, performance model of just getting the best on the very few. And I think for us, I lean towards getting more people involved. And then as a result, you'll find your 1 in a million. And so, this is, I don't know if you guys, knew Andy when he was younger, Andy Meyer, he's our communications director. He tried to play a lot of sports, and him when he was younger, trying to, kick a soccer ball around, and could have used a little help. But so the goal is really sports specialization, the question of athlete development. Can you take Andy, give him the right tools, and have him, become this? And so that's, and without him getting hurt and having him quit the sport. So, it's been like 10, 12 years ago, we did an evidence-based review, looking at all the studies that at that time had specialization before the age of 12 and after the age of 12. And at that time, there's only one sport that specialized before the age of 12, and that was gymnastics, rhythm gymnastics. And every other sport was later than 12. And so we recreated this in a more systematic way with the systematic review, with AMSSM and Stephanie Clythermis, who is our research director, was the lead author, and a bunch of us on our sports specialization committee looked at, and this is published in BJSM, 19 studies looking at performance measures and specialization. And 0 of the 19 studies was there a benefit to specializing in a single sport. There are some that suggest that they're similar, but there are none that suggest that it's better. So the average age was about 14 years old, and then and that's really to get to elite level in most other sports. John D. Fiore, another past president, had a really great and pretty simple study looking at UCLA athletes and what it takes to become a college athlete. And it actually turns out that the best chance of becoming a college athlete was actually having a first-degree relative who was a professional college athlete. So genetic predisposition is much more likely than just overtraining beyond what your genetic capacity is as well. And then, of course, it helps to be LeBron and have his kids, probably have a pretty good chance of doing well. So, and I always tell parents, I go, your decision about whether you specialize that or not is your decision. It is, it's a little bit more of a risk. So one example is this is a French pediatric study where you have sport samplers and who could try a lot of different sports, and they tend to have higher participation rate in sport 5 years later. And then sports specializers who tend to do better performance-wise have lower participation rate in sport 5 years later. And these are starting at elementary school age. So it's your risk, and it's the same risk I want to make sure I don't take with my kids, is having them exit the sport because you wanted them to be so successful from a performance point of view. So what we see now, and this is, I was just on a podcast yesterday, more consumer facing, talking to parents and coaches, is an estimation of what have we done to the system. And I think we've taken a model that was really play a lot of sports, specialize late, to one that's actually, that was originally a long-term athlete development model. And I call it now an STD, a short-term development model. And that's actually probably moved things up about 4 years. And that's the type of injuries that we're seeing. Our specialization ages are a bit earlier, and also the types of injuries we're seeing. And those of you who have been practicing a little bit and seeing it, we're seeing, I at least am seeing patellar tendinopathy changes that I never saw in ultrasound in kids much earlier at 14, 15 years old, which we would see them in college and maybe beyond. And I think that's the acceleration of the intensity of the training as well. So the problem with that is there's actually a little bit of data that says that short-term development is effective. So if you do want your kid to be the best 12-year-old or 14-year-old, you just train them a lot, and they probably will be successful by that age. What happens after that is definitely up in the air. And I think that's where the problem is that you do see short-term successes with early intense training, whether it's specialization or not. And so, and let's face it, look, we all get proud of our kids. And, this is my kid when he was 7, and, he's hitting a tennis ball. And I like this story because actually you might notice that he's actually wearing baseball pants because he was on his way to baseball practice. And I would just stop by to say hi to a few tennis friends. And then he jumped in and wanted to hit a tennis ball. So, again, if I wanted to, I think he could even be better. You get excited, and, coaches tell you your kid's so good and you should do more. And so I see the reasons why parents do it. But so our job is to message properly when that should happen, because it's going to happen and should, but when it happens is important. So, there's a performance and participation pathway, but the bottom line is the performance pathway is where you have potentially more attrition, more injury, and maybe less quality of life, but we'll go through some of those studies. Okay. So another factor that maybe influences the decisions about whether or not you specialize is unfortunately the reality. And this is the NCAA goals data. This is a 2015 sample, which shows the percentage of athletes who specialize before the age of 12 again. As you can see, this is boys at the top, girls here at the bottom. And I'll come back to this about sex differences, but girls tend to specialize quite a bit. And you can see the problem sports: gymnastics, tennis, soccer, basketball. And why team sports have become a specialization problem is still a tough pill for me to swallow. I can see it in individual sports because of the need for the technical part, but we've definitely transferred this to team sports. And so most of them do specialize. So if you do look at it, there is a reason why a lot of kids are specializing as well too, because they're seeing it. This is the patterns that we're seeing in a number of sports. We published in Sports Health on, at least based on our impression was of the kind of entry times for specialization. We recognize that there are some early entry sports: gymnastics, swimming, diving, technical sports. Most sports, individual and team, we typically recommend middle adolescence, and then there's endurance sports we actually do better as you get older and into adulthood. So no need to really specialize in that group. Okay, the next question that we obviously get asked is, does it lead to injury risk? And we've obviously put a lot of stuff out there, but sports specialization research was kind of like throwing stuff out there and see what happens. This is the old school way to do research, right? And I think still one of the best studies done was not done in the US. This is a Toya Training of Young Athletes study done in the UK about over 30 years ago, looking at 450 athletes. And in the 4 sports, remember I mentioned earlier from the goals study: tennis, swimming, gymnastics, and it was actually soccer and not basketball, and followed them. And what was really neat at that time was there was low rates of injury, low rates of weekly exposures of really around 10 hours a week. These are elite athletes and really positive benefit of sport. So they didn't actually find too many bad things. I haven't had one single study that's demonstrated low injury rates or low exposure. And I've been researching this for nearly 20 years. So 30-year-old data back then. So this culture change has really shifted. And that was done in the UK. You know, it would be nice to see populations of that studied here, but I can tell you some of these populations are hard. Try to get into gymnastics club and follow them for 2 years. And in other areas, it's not easy to do youth athlete research longitudinally. You know, Bob Molina, father of youth athlete development, popularized this term before I ever studied it, but had basically warned it. He's a retired now, a great guy, but a PhD researcher, and said, look, this is going to happen. And he called it sports specialization. We probably were the first people to show an association with injury, and this was in tennis players, about 500 or so youth tennis players, who the majority of them specialized at about 10 years old, and that data is similar 20 years later almost, and also same kind of data in WTA when we looked at professional tennis players. So it's a culture, not, and the same thing will happen in gymnastics. And whether it's right or not is hard to say, but right now that's the current culture. So we know that they're more likely to pull out of tennis tournaments because of specialization, but it wasn't good enough. And so this is where we started that trajectory. And we went to AMSSM for foundation funding and looking at a lot of other um, sports. But what happened was, based on a very limited data, we started putting out a lot of position statements and a lot of immediate recommendations based on very little data. In fact, there was a time, and now we're past that I had been on about 7 position statements, and Mint Coker did a systematic review, and there was only 3 published studies on it. 2 of them were mine, one of them was Greg Meyer. So we had too many position statements about this with very little data. And so I think we're catching up with some of the data, which is helpful. And some of that, the simplest thing is the more higher degree of specialization, you had more not only overuse injuries, but serious overuse injuries, even while adjusting for all their factors. And I think probably most of you have gotten to that part already. And that's been kind of corroborated with several other investigators around the country who've done a great job. The Wisconsin researchers and David Bell and Tim McGuine in that group have been some leaders in that as well too. Cynthia Labella, Andrea Straglione are co-investigators of mine, and they put out great stuff, and others too. And we're seeing similar patterns in other populations. And so we have to start asking ourselves, like, what tools can we give young athletes to help them through this process? Because it is it's gonna be happening. It's hard to change this culture. And so we've published a number of things on that. Some of them are looking at biomechanics and counseling on it, and we'll give you those very specific things that you can do. Integrated neuromuscular training is actually movement patterns about mechanics and starting as young as possible, which this in concept is excellent. The problem is, where does it happen? We can't get into schools. PE is a dying concept right now. It's once a week, and who can deliver this? And it doesn't happen in sports. I mean, I'm a volunteer coach, and I do a few things, but if I start taking kids out for half their practice working on their squat and their lunge, like, parents would be yelling at me saying that my kid can't even hit a ball yet. So where is this going to happen? So I think that's part of it as well too, because our culture shifted away, scholastically at schools, to be able to develop kids who have strength, and we've lost strength in our kids as well. So again, going back to the kind of transition of the study, we said, hey, look, we got to look at all athletes. So this is back when we did, our study about 1,200 youth athletes, and 800 or so were injured, and 400 were controls, and seeing primary care doctors or pediatricians for sport physicals, and we found volume-based injury risk and sport specialization risk for all the things we talked about. So that is training more hours per week than your age. A sports training ratio is having more than twice as much of organized sport versus free play. We're finding, and we've submitted a few other papers right now, that free play may very well be protective. What that means is that you may be able to tolerate higher loads, but if you're self-directing your physical activity, so you can have high physical activity loads, but not necessarily get the same injury risk. and of course year-round training greater than 8 months a year. And these are all highly significant in mostly in univariate and multivariate analysis. So to date, I think it's the strongest clinical data set we've had. And we've followed up with several studies that all kind of, even a 2 and 3, 2 to 3 year outcome studies, almost similar findings again. So I think, I think, and it's not just us, it's multiple investigators. So I think we've established those associations. I do want to remind people that not all, just getting injury doesn't mean the same. So not all injuries are the same. So we want to make sure that we're counseling people on the difference between low risk, intermediate, or maybe high risk injuries. And in youth athletes, bony injuries tend to be, for the most part, higher risk. And I would classify, though we classify those that take you out of sport for more than 1 month as a serious overuse injury. And that's in most places. And apophysitis is probably one of the examples where it may not be high risk, but low back stress injuries, bicondylar apophysitis, little league shoulder, hip and joint, and wrist injuries that we're seeing. I see a lot of high level tennis players have really changed, and so we're seeing that type of high risk or serious overuse injury is about 25% of the overuse injuries that we're seeing. And that's actually a pretty significant amount. So 1 out of every 4 of our overuse injuries. And for those of us who are non-surgeons, we're going to see the data somewhere between 50 to 60% of the injuries that you'll see in clinic will be overuse injuries if you're seeing an athletic population. And so we have to be careful with the stuff in red. In our we published in OJSM our 2 to 3 year outcome study. I don't know if this is good or bad news, but 2/3 of the athletes in there were some sort of repeat or recurrent injury. We did not see as many new injuries. And so it's good for business. We get a lot of repeat customers, but it's bad that the same kids are getting hurt over and over again. And we know who they are. We already know who they are. And again, does this change based on sport? Cynthia Labella's group and our group looked at this, about 2017 study. And obviously it's a little slanted because I have a lot of tennis players in this study, but these are the proportions of athletes who specialize in, again, tennis, dance, gymnastics, and then soccer to follow. So remember these patterns, because we're going to talk about the female athlete as to who's really driving this problem. So, and again, this is more of an individual sport problem than it is a team sport problem. So we have this one study looking at just the adolescent female athlete, and we just gave our preliminary data at that point. And sadly, as we looked back at Anna Buser, my current med student, has just submitted a publication for looking at sex differences in specialization and training patterns. And we realized there's almost no data on sex differences. And it's a big oversight on my end. We did have one publication. And what we did realize is that sex differences, girls are the bigger risk. They're the driver of most of these types of injuries. And that's actually a problem. Now we say concussion's bad, ACL injury risk is bad, and you have, potentially red S, and now we're adding overuse injuries is the high. We have a lot of reasons why a girl would not want to continue to play sport. So we have to be really cautious of how we're messaging that. Another thing we found was, we call it our more money, more problem study, is that those kids who actually play the most but had a lot of free play did not have the same level of serious overuse injuries. It's the kids who had came from the most money who had the highest rate of serious overuse injuries. And again, organized sport with coaches and a lot of competition seem to be higher risk than those that can self-direct. So you can still have a lot of physical activity if it is on your own terms. And again, we've lost kind of that culture of free play, and that's what the sports training ratio looks at. That's more money, more problems. So finally, what are the health consequences of the current training models that we have? There was a special issue in Journal of Athletic Training. We kind of reviewed that. And one of the things is we want to call to attention that this whole issue of youth sport training is actually pretty important. If you say 60 million kids are playing sports, a third are highly specialized, that's a lot of kids that we're talking about. So we want to make it a public health issue. There's a big reason for that too, is if you're going to get funding, it's hard to get funding if you just call it sport. So this is a public health issue of how we're treating our youth athletes. And current models right now that's where I'm actually less concerned about the individual risk, because a family can choose to do that, and if their child gets hurt, and that's a decision they have to come. But the current model is actually pushing out a lot of kids from sport, and we don't want to have decreased opportunities. All our research could be summarized in this 1 minute thing. And tell me if you can't hear this, Amish. Yes, that's my son, the actor. He's like 10 now. Can you hear it or no? No, can't hear it. Okay. Yeah, I'll pause it. Thanks, Margot. Um, so basically, this gives brief summary, and the three things that we try to read is there's an increased risk of overuse injury specialization. There's increased, you have more opportunities with free play. These are injury prevention models, and train less hours per week than your age. And so, with that, we know that there's an injury risk, but I think if we're going to be honest with ourselves, we should be looking at whether or not this is affecting young athletes' quality of life. This has been accepted for Clinical Journal of Sports Medicine. We have a multi-site study we followed. I can't remember, 400 athletes, I think, who have quality of life measures, and we found we have a longitudinal study we're going to submit as well too. But in the short term, the first month after an injury of either overuse, acute, or concussion, we generally found that there were overuse injuries created mobility issues, and maybe there were problems with concussion, but in large part, sports specialization did not make a change on their quality of life. And I say this in specific because I've been part of a lot of position statements which talk about the poor quality of life with sports specialization at the individual level, and also long term. And I have not seen that data yet. So I want to just be careful that we're not saying things that don't necessarily exist because of sports specialization, not because of other things, but just specialization alone. Um, and when I did a talk at our own meeting this last year, we look at what are actually the worrisome and not worrisome injuries based on quality of life. And the kids who do well are acute injuries that don't require surgery. You have just a radius fracture, you can have a bad ankle sprain, and even patellofemoral pain and apophysis. Those actually do not impact your quality of life too much. A couple of things like hip impingement, osteoarthritis slaughter seem to have a little bit more effect on it. And the ones that make the biggest impacts on quality of life are injuries requiring surgery or that are season ending and serious knee injuries, basically. Concussions. In our sample, it affected school 90% of the time. So that's where concussion really mattered. And then the chronic overuse injuries, these serious overuse that keep you out for a while. And then unfortunately, and more consistently, girls have lower quality of life than boys following injury. So those are the areas that we pour our efforts into to try to mitigate either through research or clinical or education, whatever we can do. But if we go back to just the individual itself, just the concept of specialization, we've done 2 quality of life studies in looking at parents and children. And I think we found great positive benefits on parents who exercise with their children. And we found that in large part, they have good quality of life, and that's a supportive family. So in those other 2 studies, we did not have much evidence that the specialization model was affecting quality of life. In another sample, we found that kids who had positive effects had a good parent-child relationship. The kid drove it. The kid was resilient. So if they got hurt or lost, it didn't bother them too much. And the parents didn't focus on outcomes. And so if you have that with a coach who provides that, you can actually have a healthy sports specialization model. And even the IOC acknowledges that it's possible to have that, but it takes a lot of effort and education to get that. And so then we have to acknowledge that there are specialized athletes. And so now what do you do when you have one? How do you train them? Do you just keep telling them to go play basketball if they're a tennis player? And then, when you have kids who are trying to get to elite level and they're asked to play at an academy, and you say, no, I don't think you should play that much. You got to play many other sports. You don't always get the best feedback afterwards. So we have to have good models for that. Sorry, Margot, I had to put that one in there. So they'll tell you, I'm going to train a lot, but are you going to still work with me? Okay. And I think we have to, so we put out a couple one paper in Sports Health and then an editorial on this exact concept is what is a training model for a specialized athlete, particularly through development. And this could be a 1 hour talk on its own as well, but just the 4 components of it are sports specialization and the workload involved, biomechanical components, training load progressions, and then your developmental stage or biologic maturation. We assembled what I think are some of the experts in the world, maybe me not included, but the other folks, to help give the best information that would help guide specialized athletes. We used some concepts we had done with published in BJSM and some of our data and NATA data and even AMSSM position statements on training recommendations. And we did a counseling intervention. This was a number of years ago to see, can you lower your injury risk by just following these basic rules? And we randomized it and followed them out for about a year. We actually saw, if you can see this, the lower one is the control group is that there was lower injury rates throughout the study period. We're really happy with that, but unfortunately the compliance didn't change. And so for BJSM perspective, we couldn't say, hey, it was just following the training rules because we have to get kids to do it. And as you know, with things like this on TikTok and everything else, in 20 years of youth athlete research, I found it very difficult to captivate kids' attention. We are actually repeating this study, if you can believe it, with 30-second TikTok-like videos as our intervention, because that's the only way we're going to capture it. We used to do email and real time. We can't do that anymore. So we're going to go to what we think is the best way to help educate, and that's through very short, directed educational videos. And we'll see if we can, and we have a few other rules we're adding, and improve that compliance. And then about 7 more minutes, Hamish, just so we can have time to discuss and have questions as well. Dr. Cumming, he's a PhD researcher on development, and I've spoken to him a number of times about these concepts. We're using what he has introduced to me called PPAH. We talked about in that article. We're publishing a couple of new clinical studies on this, and this is actually assessing skeletal maturity without getting an X-ray, which is great. And it only takes these bits of information, which are very easy to get. And then there's a calculation on it. We can talk offline about getting that. And you can categorize whether they're in pre-PHV or PHV, which is your growth spurt, or skeletally mature. And you can make decisions based on where they are. In fact, change their training, which is called biobanding, based on where they are. He strongly believes and has data on soccer clubs in the UK where they can really almost drop their overuse injury rate to very low if they're able to put them in biobands. But we do everything by age here in America, and I think it's very hard to do in America. So our biobanding intervention is going to be through counseling, through our athletes, through this upcoming study, and we'll see what kind of things stick. But one fascinating thing is in their study, this is small, it's about 60, not a large number, but soccer athletes, but based on their PPH alone, you could almost predict what type of injury they'd have. So it's distal to proximal. So the Seaver's disease is at the heel and the lowest, youngest group. And then you go to Osgood ladder, then you go to the hip and pelvis, and then you go to the spine, which is kind of what we're seeing too. From kind of, for us, it's like 94 to 98%. And then when you get to mostly skeletal mature areas, then this is all your muscle, tendon, and ligament injuries, which are it's a strong bias towards the post-PHV area. I think this data is so fascinating. Parents love it. Parents want to know where they are in their skeletal maturity. I'm actually making a hard push for us as sports medicine providers to assess skeletal maturity as non-surgical providers and help parents. A lot of it's anticipatory about what they should expect. How long will I be having to deal with this when I'm trying to figure out what sports to play and all these kind of things? So we're very interested in this. We're publishing on this. I hope the reviewers like it because it's pretty novel in the clinical world. So we're trying to introduce that. And so then essentially you get biobanding. You kind of counsel people differently in this phase versus this phase. They're not all the same. If I have a proximal humeral epiphyseal a prepubertal phase, it's a long road. If I have it here, it's about 25% as long for treatment. So I change things based on their skeletal maturity. Biomechanical deficits, really important. Greg Meyer one of the best researchers in the country on this. Luckily, he joined us here at Emory. This is Hamish when he was a kid. I don't know if this is one of his birthday parties when he was like 10 or 12. It's called adolescent awkwardness right here. And there he is right there. You can see it before the gray hair. Um, and so this is actually the vulnerable period, right? We think is when you have the worst biomechanics, and we need to make interventions that happen earlier during that period and not wait till they already get hurt. Okay, and that's addressing these neuromuscular deficits. And I was not directly involved in this study. My name is on the paper, but this is a great study by Greg Meyer and his group looking at sports specialized athletes and coordination deficits. We've always called it an overuse injury problem, but in this study we found that, or they found that there was actually motor deficits and coordination deficits in those specialized athletes. And so we usually associate those neuromuscular deficits with ACL tears, but now we're seeing that with sports specialization. So does that mean you should get more ACL tears, or maybe is that the reason we're getting overuse injuries combined with high loads during vulnerable periods? So maybe the intervention isn't always reduce your training, but actually work on your biomechanical deficits. And so I think that's another direction, because again, we have 20 millimeters still specialize. And so we have to give them the best environment to be able to do that. Another thing is to change things based on stage of development. So if you get a vulnerable kid who's having apophyseal issues during peak height velocity, focus on strength, reduce acceleration, deceleration, movement patterns, and work on coordination, and then take a break from that, and then reinstitute that once you've actually corrected these biomechanical factors better. And I think that's what I'm doing right now. And I'd like to have the evidence file. I push Greg Meyer is super, super busy. I said, he's done so much on ACL injury risk. I said, you got to look at interventions for overuse injury. And so I've asked him to do some studies, and he's done some pilots, and this is his first pilot study on this. And I think this particular dance should actually reduce injury risk. No, I'm kidding. That's actually, that study has not started yet. The last thing is, very briefly, there's sport-specific biomechanics. I go on court with tennis athletes to look at their biomechanics as well too. And so there may be some element in certain sports where you can look at that. Pitchers, for example, we have a pitch efficiency rating study as well. And finally, there's workload. And in our sports health study, we all know, most of you should know your asthma action plan. We created a youth athlete action plan of when to, if you have a high risk athlete, when to stop training, seek medical advice, and have more serial monitoring. When you should kind of yellow area where you have intermediate risk, and green where you can keep training. And so I think we have to be aware and categorize the risk of each athlete. They're not all the same. Tim Gabbett, some of you know, is probably the world's expert on load progressions, and he's done it at elite level and competitive professional athletes. We've done a lot of our work on youth athletes. We came together to kind of create a training model for youth athletes as far as load progressions. And we kind of defined 3 types of athletes. There's a load tolerant athlete who you keep adding on, they get through skeletal maturity, and you can keep loading them. They actually have no problems. And your injured athletes who have friends like that make them jealous. You have the load naive athlete who maybe is too young. They're introduced to load, they get hurt. You rehab them. You kind of reinstitute their there's new ceiling. They get back and they do okay. And then probably the repeat injured ones that we see, you try to progress them, they get hurt. You rehab them, even lower their ceiling and load, they get hurt still, you come back. And those are the tough ones. That's probably where we spend a good amount of our time, is why they keep getting hurt. And in every way we think, we look at workload and workload progressions and biomechanics. And so you have to kind of look at everything. And sometimes elite level sport isn't even for them. So some kids are just not tolerant. We call those load sensitive. So we try to, we want to try to keep out of this, undertraining thing too. It's not just overtraining, because if you don't develop the resilience for high level sports, then you're going to have trouble. So you can't just train really low levels and then compete at high levels. Your body's not prepared, and you can't just tell people to stop. We always modify training. We don't tell people to stop. So, and many of you are, probably used to seeing this acute to chronic workload training ratio. So we want to be able to, advise folks as well. And so we use like a floor to ceiling model on this. So, I'm going to try to finish up in like, I'll do one case and kind of finish up here. So I want to make sure we have time. And you can look in the chat to see if you have any questions or if you want to. But I want to, the last thing, I want to go over is just our concept. When someone gets hurt, we actually have to give them a floor to ceiling. Floor is the least amount they can do to be out there. The ceiling is where they're performing and training and competing their best. And how you get there is the secret. So we want rapid progressions for low risk problems, but slow progressions for high risk problems. And you have to adjust it based on the type of problem they have. And so I don't celebrate till they're 6 months symptom free and competing. And so these are some of those models that we've had before as well. So I think I'll just do, I should acknowledge 2 studies that we asked about. We have about 6 papers going out right now, but 2 that are getting published as we speak are sex differences. And I asked Anna Buser, who is my awesome research medical student, to give little snippets about what may be in there because it's not published. We're not going to give it all away, but we will just say that pay attention to the young female athlete and look at their training patterns compared to their male counterparts. And Stacy Schley, who I guess will always be my fellow, but not at all anymore because she is faculty at Boston Children's, and helped create this awesome table that we call our sports training assessment of risk. And this is, we are submitting a publication looking at identifying risk of overuse injury and prolonged return to play time periods based on these things. We're trying to replicate a little bit of what Red S did and SCAT forms, and this is us and these are all the risk factors we just kind of reviewed. All these things you take with a brief history in clinic, and then you'll be able to assess the score. And so if we get this accepted for publication, hopefully we can put that out a little bit more as well too. I'll do this one case and then we'll take a question. So a basketball player with anterior knee pain for 2 months. What we do is we try to find out their skeletal maturity. Let's say this one is in their PHV, like at 90%. We modify their training load. We don't tell them to stop. We look at the rate of increase, keep it a little slower and static, and maybe reduce the ceiling of training. And then kind of based on their skeletal maturity, tell them how long they have to do, if they have to sign up for soccer and basketball, we kind of give them some prediction of how long they'll have to kind of stay there. And all these questions are workload questions that you can ask in clinic, and I'll send you the talk as well too. I want to just kind of jump to to our final questions, and we'll take any questions we have. The simplest concept for us is just remember, in summary, pre-adolescent athletes just play a lot of things, have fun, and encourage free play. And then when you get to circa PHV, build coordination and strength, train less hours per week than your age, may still play multiple sports, some start to specialize. And then when you get skeletally mature, it's okay to kind of ramp things up and specialize and compete, but we still have to continue to work on motor control. Finally, here's our board review questions. Youth athletes were found to have increased risk of injury, except sports training ratios that are greater than 2-to-1 increase your risk, because that means you have very limited free play, and that is organized sports versus free play. And female sex, it looks to be a risk factor, and of course, high degree of specialization, training more hours per week than your age. And then when counseling family regarding sport participation, we believe that the pubertal growth phase is a riskier area for overuse injury. We do want to emphasize that resistance training in supervised settings is acceptable, and AAP does advocate for this, especially even at young ages, if it's supervised and done properly. We actually do not know the age of specialization despite all these studies and risk of injury. And then yes, we should definitely focus on strength and coordination and pubertal growth. Okay, so we have a lot of work to do still, but it has to be more specific and targeted, and not just saying sports specialization is bad, don't do it, but how does it affect return to play time periods? How does it affect your quality of life? What interventions can you do to help keep a specialized athlete healthy? And I think then we can work together, and when you work together, only good things can happen, right? Just like this video. So that's my kids' baseball team this year. So thank you so much. I want to save a few minutes here. I know it's quite a bit of information. And I'll be happy to send the talk along to, I don't know if you guys do the talk or just record the video, but it's always a pleasure to do anything at all for AMSSM.
Thank you very much, Dr. Jayanthi. That's been fantastic. We've had a really excellent whirlwind tour through the world of sports specialization there. One question I've got is just thinking about our lives as clinicians, what are the opportunities we have as physicians to kind of influence this decision making of kids and parents, and be able to discourage early sports specialization if we feel it's appropriate to do so? When do you see that conversation happen?
Everywhere. So, for some, it's only in the office, and let's do shared decision making because I might discourage. I don't judge, right? And I have a lot of athletes who specialize early and train and get hurt. So I try to work with them on working with them when they're specialized. But so if you're one and the same clinician, you're just busy and you're in the office, at every point you have an opportunity. I tell them, I go, this injury is an opportunity for me to help educate you on your athlete development. The second thing is your local communities. I don't know about you. I coach every kid of mine, and every kid, we changed the culture of all the leagues. When I coached my kid in baseball, we changed the whole culture of how all the teams we play is because of the way I might coach and emphasize what we think are the right things. And then lastly is a lot of you are influential people. We have some influential people in this organization. It's so awesome to see who are national governing bodies who can make changes. You name a sport, we have someone at AMSSM, if not multiple people, who are in influential positions to help guide them. And so for me in tennis, I'm on, every committee you can think of and putting out information and educating parents. And I think sport-specific approaches are the way to do it. So for those young but enthusiastic fellows or early faculty or even faculty with experience, people like Margot Patukian have a ton of it, like a lot, those, you have a ton of influence, use it. We have to advocate for things on the board. And I would be cautious though. Remember, NGBs and even local communities, they may invest into sports specific and sports specialization. That's why I'm cautious to say it's not just an all bad thing. It's about providing the right environment or providing guidance for those that do decide to do it. So
Excellent.
that,
I'm going to actually ask Maria to ask her question. She had a great question about female athletes and their risks.
mhm. Hi, Maria.
Just unmute first, Maria.
Hi. Yeah, so I was wondering, have other risk factors been identified for female athletes besides training time period?
Well, so I want to certainly acknowledge that I am not the only researcher by any stretch who's looked at female athletes. So I don't want to in any way say that, but I will just say, simply put, and I admit to, in our letter to the editor, I have been neglectful of not always looking at sex differences. So we are actually now making sure that every paper we look at sex differences. And I've had, unfortunately, too many papers that didn't do that. So in our current look at it, we are seeing what seem to be consistent differences in training. Other great investigators have seen differences in biomechanics. So we're combining these things. And I think that gives us maybe a pragmatic approach, not just for the ACL injury risk, but I think you take that combination and I think we can effectively reduce the overuse injury risk. But it has to start earlier. And like I said before, I'm also scared of putting out some of this information because it's telling female athletes that they're more at risk in every way you can think of. And I don't know, Margot, do you have can you help me with that? Like, how are we going to take the information that we have that we know it's not good, but not scare away athletes or female athletes for this? I'm actually a little worried about publishing some of this stuff.
Margot, feel free to jump in.
Yeah, no, honestly, Neeru, it's an important question, but if you look at the literature, unfortunately, there's so little literature that is female athlete focused. So, that's one of the major issues that we deal with is that we don't have a lot of data that's really specific to female athletes.
Yeah. So everyone on your, it's not hard to do. And I am embarrassed that I'm here telling you now, I don't know how many papers through this. All you got to do is actually, include sex differences in every study you do. You can do female athlete only populations, that's great, but all you have to do is make sure you're looking at sex differences in whatever paper you're doing, and then that'll be very helpful.
Agreed. Margot, do you want to ask your follow-up question?
Yeah, sure. I mean, Neeru, I think you pointed out, that it's I think really importantly asking kids what they think, right? Because how many times do we have the parents that want their kids to get a college scholarship, and so they're sort of pushing them. But what if your son had said, "Yeah, Dad, I want to play tennis 4 days a week"?
Yeah, and I get asked that question. I was on a podcast for that. So I have another son who actually likes chocolate a lot, and he would like to have chocolate for breakfast every day of the week too. And so we have to, as parents, actually guide them in the right way. And I get parents say, "Well, my son just loves it." And I say, "Well, you're also a parent. Like you can't have them. They love screens. They love video games. Like it's fine to do. So you have to at least draw some line." The way we've approached it is actually so far, I said every season you get to pick your next sport. That's how we've approached it. And so I give them the list of things that work with our schedules, and then they do that. But there's a time and a place to do that. I really think so. And so I was on a podcast with a tennis dad who he had 3 tennis kids. One ended up playing college and then quit, and went through the whole process. And he's just filled with regret. His whole life mission now is to actually do it educate parents in the right way. And so I think I think there's a time and a place to do that. I think skeletal maturity is one, and maybe earlier than that, but if you have to have the right environment.
Excellent. There's a really good question from Shane regarding social economic status and overuse injuries, which he touched on a couple of times. And perhaps the fact that the free play component may be influenced by social economic status. I certainly think you're absolutely right with the more money, more problems statement. The reason that we've got this problem is because it's youth sports has become commercialized. I mean, let's be honest. There's people with money willing to throw thousands and thousands of dollars at training their kids in various sports, and that's what's led to specialization. So, how much influence do you think social economic status is having, and the factor of free play?
Well, what this tells me is that we know 2 things about socioeconomic status. One is there's a lack of access for those who do not have resources, right? But when they do have the correct environment, they have parks and places to play, they probably do it the right way, which is they go and play for fun. And they're not in as much organized participation, coach-led private sessions and all these things. And there's so much healthy benefit from that. So we have our work to do in that stratosphere. This is, we've created this own problem in the high socioeconomic areas, but it's not happening in low socioeconomic areas. And what's happening there is in under-resourced, poor accessed ability to even be physically active, which is actually a much bigger problem than a bunch of, rich kids getting hurt, to be honest, as far as I'm concerned. I actually think we have to create more opportunities for the other kids to do stuff. And that's humbly saying, because unfortunately, most of my data is on the kids, that have the resources.
Yeah, I think there's an opportunity there for us to collaborate with other countries, because we think about social economic status in terms of the first world, and there are many countries around the world that perhaps have less resources than Europe, the UK, or the USA, that people are playing sports, and there's an opportunity there to see how other countries experience youth sports differently. And I think my background's in rugby, and I think of Fiji as an example of that, where both boys and girls are playing rugby from 4 or 5 years old, but not necessarily getting hurt doing so. And there is neuromuscular development, coordination as part of free play, just playing rugby in the patch of grass that they have. So I think there's a huge opportunity there for us to be gathering some of this data globally and not just centric to the first world. So maybe that's another. We're giving ourselves more work here, but we need to include more women and girls in the studies that we're doing, and we need to include people from all backgrounds and perhaps globally if we can.
Absolutely. And then do you mind, Margot brought up an excellent point, and if you just give me 30 seconds to respond to this. And Margot, we had very specific discussions about this. What she's talking about is Roald Barr, who's out of Norway, and he runs the IOC meetings, spoke on this and actually wrote an editorial about 7 years ago that screening programs aren't effective in that you don't screen and find a portion of the kids or athletes and then only apply an intervention to that group, because other people may need the intervention as well too, so it should apply to everyone. I completely agree, and you'll notice that we specifically do not say screening. This is an assessment of risk, which he agrees that you can assess the risk. In fact, when I talk to the statisticians, they use the area under the curve as a prediction model. It's not my term, and I said we have to be soft with that. So when we submit our publication for this, we're actually making sure we're trying not to use those terms, prediction of injury or screening. But these are assessment of risk, which you can do. And the intervention that we are going to apply in our interventional study, we have 12 recommendations on training that it's a crossover study. Everyone gets all 12. So I totally agree. There's no reason not to tell everyone all the information. Even in our studies, we're doing crossover randomization. So thanks for bringing that up. And of course, you're ahead of your time because we literally just talked about that.
And in the chat, Andy's highlighted that this was an annual meeting research summit 2 years ago, I want to say, Neeru, is that right?
I think it was like it was actually about 5 or 6 years ago. Their publication
Was
was
it
like,
really?
yeah, it's been a little
Time is
while.
flying. I'm always wrong with my guesses how long ago something
Yeah.
was. But it's certainly a hot topic and often does crop up at our annual meeting. So for all those that are interested, keep your eye out for what's on the agenda for the national meeting in the spring. And I just wanted to finish up by thanking Dr. Jayanthi for a really excellent session this evening. That will get lots of hits, I'm sure, on YouTube over the next couple of days. Appreciate everyone's comments and questions, and thank you. That's been great.
Awesome. Thank you all for joining, and look forward to seeing you guys at AMSSM. Bye, everyone. Bye, Hamish. Bye, Margot. Bye, my fellows.
Margot.